Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on bronchiolitis obliterans under the section of respiratory medicine. What is bronchiolitis obliterans? It's an irreversible progressive airway obstruction, and it is caused due to submucosal bronchial fibrosis preceded by bronchial inflammation resulting in epithelial necrosis. The causes of bronchiolitis obliterans are quite varied. However, the commonest ones that we see in practice are in patients who've had lung and or heart and lung allograft transplants. And if they have this condition, it could sometimes result to transplant rejection. Connective tissue diseases, especially rheumatoid arthritis, is another culprit. Toxic fume inhalation, infections such as viral infections and mycoplasma pneumonia, drugs including penicillamine, radiation, and other autoimmune conditions such as ulcerative colitis. As for the signs and symptoms, these are really quite non-specific and insidious. The commonest one is exertional dyspnea, and patients frequently complain of chronic productive cough. Objectively, there can be reduction in FEV1, especially in patients post-transplant. An examination is frequently unremarkable in early stages. However, in later stages, it could cause wheeze, end inspiratory crackles, and respiratory squeaks. The list of investigation for a potential case of bronchiolitis obliterans is really quite long. However, as anything else in medicine, having a thorough history and clinical examination is key. This is followed by bedside observation to make sure that the patient has enough oxygen levels and obviously supplementing them with additional oxygen as needed. Pulmonary function tests will show an obstructive defect. A chest X-ray may be completely normal at initial phases. However, at advanced phases, it can show fibrosis and or hyperinflation. A HRCT is an exam favorite for MRCP in the case of bronchiolitis obliterans, and these frequently show bronchial wall thickening of segmental and subsegmental bronchi with mosaic perfusion or pattern. ABG, or an arterial blood gas, will show a type 2 respiratory failure. If you like a recap of respiratory failure, in which we will discuss in detail about the differences between type 1 and type 2 failure, please click here. Lung biopsy is the only method of having a definitive diagnosis, as it will allow you to look at the tissue. And if that is not possible, cases can be considered for referral to tertiary centers for consideration of VATS or video-assisted thoracoscopy. The management of bronchiolitis obliterans is really quite non-specific, unfortunately, as the prognosis is really poor and it's not really a single drug that can treat the condition. Normally, what's advised is to try to optimize the management of underlying condition that you think has led to development of bronchiolitis obliterans, and then treating the secondary viral or bacterial infection with the correct agent as appropriate. As discussed, the prognosis is really quite poor, and the mortality is between 25 to 56% depending on the literature. Most patients will unfortunately die due to infection or respiratory failure. So let's do some questions. A 60-year-old lady with a background of rheumatoid arthritis presents to the respiratory clinic with a 2-month history of progressive breathlessness associated with productive cough of clear sputum. Her spirometry shows an obstructive defect, and she has undergone a HRCT that was requested by chest physician, which demonstrates bronchial wall thickening of the segmental and subsegmental bronchi with mosaic perfusion. So hopefully, if you guys were listening, you will realize that the HRCT finding is very specific and highly suggestive of bronchiolitis obliterans. Given the likely diagnosis, which of the following statement is correct? A. Treatment with steroid is indicated. B. Rheumatoid arthritis is not associated with this condition. C. Definitive diagnosis can be obtained via lung biopsy. D. The condition usually has excellent prognosis if rheumatoid arthritis is well controlled. E. Her FEV1 will be normal on spirometry. If you guys were listening during the video today, you will realize that the correct option is going to be option C, which is definitive diagnosis can be obtained via lung biopsy, because it will allow you to give tissue to the lab and they will be able to have a look at it and find out what's actually going on. But just for your own learning, in terms of going through the other options, treatment with steroid is not indicated usually in the cases of bronchiolitis obliterans. As you know, unfortunately, it's one of those conditions that has very poor prognosis and there is no single treatment that can actually improve it. Rheumatoid arthritis is associated with this condition and in fact is the commonest cause in terms of the connective tissue diseases that could lead to this condition. The condition doesn't have an excellent prognosis even if you have the underlying conditions such as rheumatoid arthritis very well controlled. And FEV1 will normally show an obstructive pattern as opposed to a normal pattern on spirometry. Thanks for listening to this episode of Bite Size MRCP. If you like what you heard today, give us a thumbs up and hit the like and subscribe button to make sure that you don't miss out on our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.